By the people, for the people, the gathering to get healthcare now. Chapter 12. Organization of the physicians into local teams. In increasing local independent physician associations, IPAs, it's imperative to find physicians that other physicians trust and respect. They must be intelligent, articulate, and caring as the best teacher you ever knew. The primary goal of the team is to relieve suffering. So the physician must be dedicated to that goal while having the attributes of a good teacher. It is possible to find such physicians. Regardless of your experience and knowledge in the administration of IPAs or similar type organizations, the job cannot be done without the help of physicians like those described. Undervaluing that role is the road to the demise of the local physician team. However, this undervaluing of the physician's role is the road most often taken by those in power who want to organize a network of physicians to serve the budget of the health plan and the pocketbooks of the key investors. Leadership based on top-down business models often results in the failure of the healthcare system. The clearest evidence of the failure of our current healthcare system is that it costs twice as much as healthcare purchased in other developed countries. In the U.S., most medical delivery systems run by managers, hired nurses, and medical directors have as their unavowed primary goal the generation of money for elaborate business structures feeding corporate needs and profits for capital investors. If, however, the main goal of an IPA is the alleviation of suffering, the persons in charge must have an in-depth knowledge of diagnosing and treating sicknesses and injuries. The managers must have a profound respect for peer relationships and sound economics. A lay organizer who is outside the medical team, the core of the IPA, is a peer only in a nominal sense and will not necessarily have the respect of the medical group. There have been great physician leaders directing IPAs over the last 20 years. Our company has worked with many of them in managed care plans, in quality assurance committees, and in the direct care of patients. There are still many such people available to direct IPAs today. Find them. Find them for your group. Hierarchical structure in business is the usual operational model. In this model, leaders direct and perform important roles. But that's not the practical model followed by most physicians because they have small staffs and do not need middle managers. Consequently, when physicians participate in a large organizational structure like an IPA, they often overlook the role of middle management and run their organization much like they run their practices. It's often a struggle to build a practical structure around physician teams because it's counterintuitive to the physician leaders. Despite organizational difficulties, leaders of some IPAs have been able to reform the medical delivery and finance systems from the grassroots. Such leaders have been able to bring from 50 to 100 of their fellow physicians to form the IPAs, with 438 IPAs so far in the United States. To win over the initial group, promoters followed up with personal visits to each of the physicians to explain the IPA, the plan for qualification, and the part of each doctor on the medical team. It takes about 6 months to organize and about 3 years to produce an operational team of providers. Pioneers in the formations of these teams remain convinced of the pivotal nature of the physician leader's role. Past physician leaders that have spoken the truth and did their best to relieve the suffering of everyone around them have built good teams. Sometimes they've incorrectly assumed that the primary care physicians would be the budget watchers and gatekeepers in the use of specialty and hospital services. They've also erred by assuming that the contracted specialists would behave as a group in the care of patients. It has taken several years to finally realize that it is not money that controls the cost or the quality of care. Money's not even a real incentive in patient care. The incentive seems to be pride and fear. Pride in what physicians do and fear that they'll make mistakes. Therefore, the system for communicating what is happening every day with every patient that is referred to a hospital or to a diagnostic facility is the controlling factor. The frequency of the patient contact with the primary care physicians and their management of chronic illnesses also has a dramatic impact on outcomes and costs. When the primary care physicians see patients frequently and monitor their care, there are fewer crises and fewer hospitalizations. Physician leaders must know all of the team members, the roles they play, and how they practice medicine. Furthermore, the team physician members must be reminded constantly that they're in an IPA and not in a traditional practice. Some doctors are habituated to referring patients to a very large circle of specialists, as many as 50, whom they know from their contacts at the hospitals and at medical gatherings. This number is far too large for a team that serves a small patient population. The reform of the present system must begin with specific populations of patients served by the specific IPA. There can be as many IPAs as needed to serve a whole community, and the patients can change teams periodically as they need, but open systems and lone wolf physicians and patients will not contribute to any improvement in healthcare except to make it costly and less effective. Some IPAs have been diligent in avoiding contracting with too many specialists, and in knowing that the team members must limit their referrals to team members only. Further, all members of the IPA must get the point. They must take care of the patients as they would take care of their own family members.